So I think in the essence of time, we will get started and just keep admitting people as they come. So I am Rachel. I'm the health educator with the Epilepsy Foundation of Northeastern New York. It is my pleasure to welcome Dr. Jack Lansing. He's a neurologist and epileptologist serving adults at Albany Medical Center. He received his degree from the University of New England College of Osteopathic Medicine and has been in practice for close to 10 years. Dr. Lansing currently serves on our professional advisory board and will be presenting on new and alternative treatments for epilepsy. So I will hand it over to Dr. Lansing. Again, thank you for being with us today. Floor is yours.
Thank you very much, Rachel. So my name is Jack Lansing, and as Rachel said, I'm one of the epileptologists at Albany Medical Center. So today I'll be talking about some of the emerging anti-epileptic medication and therapies. It's a little bit dense material, but hopefully I'll try and get through it as easily and painlessly as possible. So just some disclosures. I currently have no financial disclosures in regards to any of these treatments. I will use both trade names and brand names of some of the medications. If I go back and forth, it's not because of any specific bias or anything like that. Sometimes it's just easier, especially when talking with patients or colleagues, to interchange between the two. So some of the objectives, we'll review some of the goals in treating the epilepsy patients and introduce some of the new and upcoming medications and therapies that are being used. I give this talk as well sometimes to other medical providers. So sometimes I will mention the mechanisms of action. I'll try and identify how these also are just important concepts in epilepsy, just as an overarching topic. And also sometimes that'll dictate what the side effects and risks of some of the medications are and what we as providers and physicians are trying to do when we're treating individuals with epilepsy. And then we'll also try and talk about some of the non-pharmacologic epilepsy treatments as well. So in treating epilepsy patients, we really are kind of struck with this back and forth of what should we do and what shouldn't we do. Really, each individual patient or person needs to be considered as a whole when we're talking about what medication would work best for them. Sometimes keeping them on one medication, that's always the goal for a lot of people. Sometimes multiple medications. We have to think about how the medications work in the body. How are they excreted or taken out of the body? What organ systems might they affect? What other things does the patient have going on in their life? Whether or not it's mental health issues or other physical ailments or disorders. How can we kind of address all of those with one failing swoop if possible? And then also we have to know that people are people. Are you going to remember to take your medication? Are you going to forget your medication? And kind of where do we go from there? So really you do need this complete picture when treating epilepsy. And ultimately at the end of the day, unfortunately about a third of individuals cannot respond to medication. Therefore surgery needs to be a consideration, which we'll talk more about. So this is a lovely image that kind of shows you really where we've come from in regards to our seizure medications over the years. Anti-epileptic medications or anti-seizure medications, as they're often called now, ASMs, saw a significant increase in development in the 1990s. And really the goals have changed to the ease of access, minimal side effects, while also giving the most efficacy, meaning the most bang for your buck. How are they going to be able to really help decrease seizure frequency or even stop seizures from happening? As you can see, the earliest medication that was really given wasn't until like the 1850s, 1860s. Prior to that, a lot of it was thought to be spiritual treatments, whether or not they needed some kind of religious hierarchy to help kind of get rid of the possession that they thought they had. Bromides were actually the first medication that were introduced, and interestingly enough, it was introduced by a OBGYN who was trying to treat his patients who had catamenial epilepsy, meaning seizures that are associated with the menstrual cycle. And it wasn't for almost 50 or 60 years before phenobarbital was introduced, and that was once again more of an accident than anything else, as the rumor, if you will, goes, was that there was someone who was trying to put their patients to sleep at night because they were working overnight, and they gave all of these individuals in a psychiatric hospital the same medication, phenobarbital, and everyone was able to fall asleep. of those individuals, they also noticed that the ones who also had seizures weren't seizing as much. So the thought was, oh, that must be a good medication to stop seizures then. That's a little anecdotal, and I can't 100% confirm that, but that has been brought up in different epilepsy circles. Really, though, then they started using animal models in the 1930s, and that's when you start to see more medications produced. It was a long and cumbersome process, though, and it wasn't until the 70s where they actually came up with a very appropriate way of looking at individual medications and kind of creating them based off of different mechanisms of action and least amount of side effects, which, as once again, we'll discuss. This is a really important study when it comes to epilepsy. The initial study was by two individuals named Kwan and Brody, who were looking at people with patients with seizures, and it was between the years of 1984 and 1997. There was a follow-up study that was done in 2014, being published later on in, I believe, 2018 or 19, which was looking at this even more data. And what it was looking at was, here are all the seizure meds we have. What are the chances that one seizure med will stop the seizures versus them having to get started on a second medication or a third medication or a fourth? And you'll see this on the next slide. The main point was that the seizure freedom rate, regardless of when it was, even back in 1997 versus 2014, was unchanged. The probability of seizure freedom went down after every new seizure med that was started, and even the newest medications didn't really change that rate of seizure improvement. Now, with that being said, there is the caveat that while individuals might still have seizures, the side effects are far better. And that's really the new ultimate goal of a lot of seizure meds. We want to stop seizures, but a lot of them, it's also to make sure that in doing so, we're just decreasing any possible side effects of medication or overuse of medication. This is the two separate graphs showing the data. And the first slide was from the initial study back in 1997, and then the second one is from 2014 study. And if you look, what I just highlighted in red, it's showing that of all the individuals, 64% in the first and 63.7% in the second had seizure freedom off of any seizure medication. So that's just showing that after repeating the study almost 20 years later, it showed the exact same numbers. And looking at each individual drug, it showed the exact same numbers as well. And this is the numbers that we tell patients. About 50%, here it says 47 and 45.7% of people will respond to one medication, meaning that of 50 million people or so who have epilepsy, you start them on one medication, they'll never seize again. If they have to start a second medication because we've maxed out on the seizure medication, not because they have side effects or anything else, but they need to start it because they keep seizing, only about 13, or in the newest study, 11% of individuals will respond to a second medication. And once that's maxed out, the chance that a third medication or more would provide them with seizure freedom drops significantly. So only about the remaining, only 4 to 5% would respond. So just giving you an idea, I tell people about 2/3 of people with epilepsy will respond to seizure meds, and about 1/3 will not respond, meaning that other treatments such as surgery, devices, and other non-oral medication therapies might be necessary. Obviously, I know that the goal is to get it so that medication is the ultimate way, but for right now, this is kind of what we're working with. This was a great secondary thing that came out of it, and just to kind of give an overview of what it's showing, this is a colored representation of the anti-seizure medications that used to be prescribed and how they have changed over the years. So with more available anti-epileptic medication, the prescribing patterns have changed, as it shows here. So green was carbamazepine, and brown is valproic acid, red was phenytoin. As you can see, sorry, I apologize. Green is phenytoin, red is carbamazepine, and brown is valproic acid. As a initial medication, as well as all medications, it really did kind of stop being prescribed as frequently as years went on. And then newer medications, such as the lighter purple that's seen, as well as the yellow, which were medications like Keppra and lacosamide, started to become more available and more ready. And now, as it looks here in 2014, which once again, this is about 9 years ago, you can see that there's not one medication that's really dominating one individual area. It's more of multiple medications, and a lot of the older medications not necessarily have completely fallen out of favor. They're just not so widely prescribed. A lot of that has to do with side effects, as well as the fact that if efficacy is about the same, how well they're treating the seizures hasn't changed. Why not make sure that we use a medication that's not as cumbersome to have to follow up on, as well as cause potential changes in the future to the patient. So some terminology, and this can change with time, even as I say, like anti-epileptics, some people will say anti-seizure medications, what have you. And people will often refer to all of these as anticonvulsants. But to give an actual true definition to some of these terms, an anticonvulsant is supposed to be a medication that is stopping the seizure as it's happening. Really, any seizure medication could be an anticonvulsant, but a lot of times people will think of these as also our benzodiazepines that are used initially. But also, like I said, typical classic seizure medications can be in that consideration. Anti-epileptics or anti-seizure medications are supposed to suppress seizures in epilepsy. So a long ongoing risk for seizures in an individual. So it's kind of like a preventative medication to make sure it doesn't happen again. I bring up these terms just because the new mentality in epilepsy is we want to have anti-epileptogenics, because what that's going to be is not treating the seizures, but trying to treat the cause of the seizures. The goal is to make it so that you never even develop epilepsy. That is quite a tall task, obviously, because you have to do a lot for that. And there are certain things at play, such as structures that might be difficult or impossible to remove, or it might be a genetic issue, or worse of yet, idiopathic. We don't know. We just can't figure out why it's happening. But this is ultimately the goal, is to make sure that we figure out why they're seizing and treat that most directly. I won't belabor this, but this is just kind of showing there's multiple ways that these seizure medications, the classic medications, as well as the new medications, work in your system. So sodium channel is by far the most common. And that used to be one of the mainstays. As you can see, some of the older medications like valproic acid, fosphenytoin, carbamazepine are listed here. It's still used, however, as such as oxcarbazepine, lamotrigine, lacosamide, eslicarbazepine. And then there's others that have more unique forms of how they work. Ethosuximide, primarily used just for absence seizures, it has a completely different mechanism than every other medication. Carbonic anhydride, that is used to help decrease pressure as well in the brain, but also can help with seizures. I bring these up because sometimes we use these mechanisms of action for their side effects, because sometimes the side effects are also going to treat other conditions. So for example, topiramate, zonisamide, and acetazolamide can also treat things such as migraine, or they can also treat things such as idiopathic intracranial hypertension, or as it used to be called, pseudotumor, but they also work as seizure meds. Levetiracetam, otherwise known as Keppra, works very uniquely as a synaptic vessel modulation. And then GABA and glutamine are two very individual things that are happening, two individualized neurotransmitters in the brain that have different functions. GABA is providing inhibition, so it's trying to bring down the electrical activity, if you will, whereas glutamine is the excitatory, so it's trying to excite the brain. I always tell my patients, if you think of seizures like the electrical fire that it is, glutamine, because it's exciting the brain, is kind of building that up. And so if anything, you'd want to bring either that down, or you'd want to increase the GABA, increase the inhibition. So it's almost like you're trying to cover the fire. GABA is used very frequently with a lot of these medications. So phenobarbital being the oldest and most common, but other benzodiazepines as well. A lot of the abortive medications that we all know, as well as medications that are given in the hospital in emergency settings. So lorazepam, clobazam is a longer acting, that's Onfi, as it's also known, diazepam, clonazepam, midazolam, all the ZAMs, if you will. And there's some others listed here as well that are less commonly seen, but used for specific neurologic disorders. Gabapentin and pregabalin as well, used typically for nerve pain issues, but also can be used for seizures. And then glutamine, trying to block that excitatory pathway, as well as felbamate and ketamine. So a lot of what we'll talk about with the newer seizure medications, there actually is a conference that goes over this information every year in Spain. The 16th annual one was this past year, and it's usually held in May. It was May 22nd and 25th, and they talk about the anti-seizure medications or anti-epileptic drugs that are being developed. And it talks about ones that are currently being looked at, as well as the ones that are getting more and more data. There are a few that I've excluded from here, this talk, just because it could go on and on with some of the newer medications, such as bumetanide, but that becomes more of a discussion of theory and how it would help. And this, I just wanted to talk more about what's been approved, what's kind of in the pipeline. And also, when I discuss these medications, I will also say that I'll talk about what they are FDA approved for, or and try to stay away from non-FDA approved uses of some of these meds. So just to keep that in mind. Brivaracetam, we'll start with that one. I wanted to try and keep these meds that have been developed or FDA approved at least within the last 7 or 8 years, just to keep it relevant. So brivaracetam is the oldest new, and that's May 2016. It's now approved for ages 1 month and older, so pretty wide span of age that we can use this medication. First evidence was a single dose suppressing photoparoxysmal response, so the flashing lights that can cause epilepsy. Sometimes people have photosensitive epilepsy. Brivaracetam, otherwise known as trade name Briviact, was able to kind of help treat those individuals as well. It's usually used for, the old term was partial seizures. Now we say focal seizures with or without impaired awareness. That's where most of the FDA will approve medications. The mechanism of action, it works a lot like levetiracetam, here being abbreviated LAV. So Keppra. It works very, very similar. We always tell people that it's like Keppra, but 20 times stronger. And the reason why we like it is that it doesn't have the same mood issues that levetiracetam or Keppra usually is associated with. So I've had a lot of patients who will tell me that they were on Keppra or levetiracetam and had to stop because they became a bear. The patient might not say that, but the loved one sitting next to them will just nod their head and be like, yes. So that's kind of where this may take place in. And there's other reasons why this medication is being more commonly used as well, which we'll go into. It is a little bit different than levetiracetam in the fact that it also works on other mechanisms. So it also works on calcium channels. It also works on sodium channels. So it's kind of hitting a few other areas that is kind of nice. Half-life, which is an important concept, which we'll see a lot in this talk. Essentially, to reach a steady state in your body, you need to reach 5 half-lives. So 9-hour half-life, that means within 45 hours, 9 times 5, you'll end up having this medication in your system and pretty much good to go. Every 9 hours, about half of the medication dose that you took is kicked out, if you will. You've been able to metabolize. So, and then every 9 hours thereafter, it keeps having. So that's why we try and make sure we reach that steady state as soon as possible. So this has a shorter half-life than a lot of other meds. So sometimes the shorter the half-life, that usually means you have to take the medication a few times per day. Whereas a longer half-life medication, you might get away with even taking twice or once a day. Brivaracetam is typically a twice-a-day medication. One of the nice things about this medication, it comes in different formulations. So there's tablets that come in different sizes. There is an oral solution as well, which is really nice for our individuals who can't swallow very well. And very nice is the form as an injection. So there's IV, intravenous. That becomes really important for our individuals who are undergoing an emergency, a seizure emergency, or they've just had a procedure, can't swallow, can't tolerate it for any other reason. They can have an IV formulation. And this is just showing some of the dosing, and just the real takeaway from this is showing that pretty much ages 16 and older, they all get started at the same dose, which is the twice a day medication dose of 50 milligrams twice a day, and they can go up to 100 milligrams twice a day. Under the age of 16, we start talking more about weight, which is a pediatric based concept comparatively. But obviously, if we have an adult who is not weighing 50 kilograms, we need to take that into consideration, that we might have to change the dosage. There is a hepatic dosing as well. So it does go through the liver, which is a little bit different than levetiracetam, which goes and is excreted completely through the kidneys. So we do have to change it in individuals who have some liver damage. It can interact as well with rifampin. We very, very rarely, if ever, have anyone on rifampin, which is more in the antimicrobial realm. So if someone had an infection like tuberculosis, they'd be on rifampin, but we don't usually talk about that as much. But this is important to note that you would have to change this medication dose. It does go through the liver, so if someone else was taking carbamazepine with it, it can increase one of the metabolites of carbamazepine. It can also increase phenotone levels. And interestingly enough, high doses of brivaracetam can actually decrease the content of estrogen and progesterone from oral contraceptives. So there's more recent improvement discussion about that as well, whether or not it would cause people to have failure of oral contraceptive being on some medications, something to keep in mind. And this has changed, but studies had initially excluded patients who are taking levetiracetam recently. That has changed. We're starting to see more and more that brivaracetam has been used as well with some of these individuals. Side effects, pretty well tolerated, just anecdotally from myself speaking, as well as from the studies. Headache, a little bit tiredness, dizziness. That is pretty common for most seizure meds, if not all seizure meds. And I usually talk with people about that. It is a Schedule 5 medication, meaning that it does have to go through prior authorization before people can take it. Moving on to the next medication, CBD or cannabidiol. Obviously, we're not talking about our local gas station CBD that you're finding. This is more of talking about the FDA-approved CBD formulation, which is the only FDA-approved CBD formulation known as Epidiolex by trade. That was approved in May of 2018 and is approved for ages 2 years old and older. Typically used for individuals with pretty devastated epilepsy syndrome, such as Lennox-Gastaut syndrome or Dravet syndrome. You'll see Dravet syndrome pop up a lot with some of these medications and what they're either testing for or what they are approved for. Same thing with Lennox-Gastaut, but more specifically with Dravet syndrome. Dravet syndrome is a sodium channel issue, sodium channelopathy. So as I showed earlier on, a lot of medications go through the sodium channels. So as you can imagine, medications that don't go through sodium channels would be kind of a novel or a unique way of treating these individuals. So that's why they're often discussed in these newer medications. Not completely known how CBD works specifically on seizures. There's a lot of different thoughts. We'll talk about some of these things later on. So serotonin, otherwise known as 5-HT, is also involved in pathways regarding seizures. So activating the 5-HT1 receptors, serotonergic receptors. Does it change the mTOR pathway, which we'll discuss later on with another medication? And then also, does it decrease that excitatory neurotransmitter glutamate? So maybe making your brain less excitable. It's hard to say. Half-life is pretty long, so 50 to 60 hours. So now, as you can imagine, that multiplied by 5 rule, we won't have it fully in your system until you reach 300 hours. So that could mean that for it to get out of your system, it could take 300 hours, which is, you're now looking at 12 days, 13 days. So you're looking at almost 2 weeks before a medication gets in your system and out of your system. So I tell that to individuals too, that it might take a little while before you really get a full appreciation of it. It also means that if they become toxic on it, the effects might last longer and longer. And we'll talk a little bit about that in a second. It's an oral solution. Dosing does go through the liver, so they have to make sure that we check liver enzymes before we start it, because we don't want to damage the liver or cause any ill side effects and not know whether or not the liver has taken a hit. Start off at a low dose of 2.5 milligrams per kilogram twice a day, and then increase until you can reach a match of 10 milligrams per kilogram. So it is weight-based. And there have been some people who do more rapid titration. And once again, if the liver has shown sign of damage, you have to decrease how much you potentially can give them. It's usually taken with food. It is fat soluble, so you try to make sure to take it with food to be better absorbed. Notable interactions. So it can interact with diazepam, can interact with valproic acid. Very notable, it interacts with clobazam or Onfi. So there were case reports in the past where people were taking cannabidiol and they were taking Onfi, and they were coming in very, very confused, very tired. They would check a clobazam level and it would be normal or maybe slightly high. And so everyone said, okay, well, it's not the clobazam that's making them tired. They then found that when clobazam goes through the liver, it breaks down into another metabolite called N-desmethylclobazam. That they found could be as high as 3-fold, even higher than what it should be. The half-life of that is closer to 100 to 120 hours. So now you're looking at 500 to maybe even 600 hours of a half-life. So now we're talking weeks of someone being really, really confused if taking the two of them. So now whenever we order this medication, usually those two things are checked simultaneously, a clobazam level as well as N-desmethylclobazam. And I have seen cases of that by far. It's also important, right now we're talking about, once again, FDA approved CBD, but that's why it's also really important from a provider perspective to ask, are you taking any CBD products, or are you taking any, or are you smoking marijuana? Because that could definitely affect your seizure meds. Side effects, it can increase liver enzymes, which is dose related, as we talked about, make you more tired. It can cause suicidal behavior and ideations. So that's a really important thing to screen. Make sure there's no underlying anxiety, depression, or mood disorders that might worsen with it. Now, this is a Schedule 5 medication as well. So it does have to go through the provider going through prior authorization. It can take a little time to get. It's important because all other CBD products extracted from cannabis or marijuana are Schedule 1. And that's important because Schedule 1 means that it's actually a narcotic. It's something that has high risk of abuse or harm, no limited or no medicinal value, and illegal to possess. So really, in order for it to meet FDA approval, it has to be less than this amount of THC. THC is the component in marijuana that is actually hallucinogenic. So that's the part that makes people high. So that's why Epidiolex is more specifically targeted as an FDA-approved medication. It's to try and eliminate any exposure to THC. Now, that leads to generic CBD oil and products such as FDA-approved. So generics could be gummies, it could be tinctures, suspensions, tablets, or it could be vaporized. And obviously, with the legalization of marijuana in different states, including our own, these become much more widely available, as well as easily obtainable. What are you really getting when you're getting a generic versus like an FDA approved? Because people come in all the time and ask, what are your thoughts on marijuana? To the point where I almost feel like I'm a drug dealer by the time I get done with the appointments with a lot of these people. So just looking at this was an interesting study from about 7 years ago, where they actually took a bunch of non-FDA approved CBD products from different companies over the internet, and only about a third of them were labeled correctly and how much you were actually getting when you got it. About half almost were under labeled, and a quarter of them were over labeled. So you're actually getting more CBD than anticipated. That's one of the components about FDA medications versus different non-FDA treatments, such as even multivitamins and other vitamins you get over the counter. They can range in how much you're getting. The actual frequency of it depended on what formulation you got. The most accurate were usually the oils, whereas the least accurate were the vaporization liquids. So, I mean, literally an eighth of the vaporization liquids were actually appropriately labeled, whereas about half of the oils were. And most interesting, there was a fair amount of the product, about a fifth of them, where they actually had THC in them, even though it wasn't labeled. So they were actually getting something that could make them high, if you will. Some of the levels, and depending on what state you're living in too, were actually able to lift or elevate the levels in your system to the point where you could be at risk of prosecution under marijuana laws. In addition, there was a lot of adulteration and contamination in the generic oils and tinctures and what have you. There was synthetic cannabinoids in some of those, otherwise known as K2 or spice. That has been shown to have multiple issues, such as worsening seizures, also putting people at risk of vasculitis or even stroke. And then they also found certain carcinogens in some of the preparations, such as these things called PAHs, polycyclic aromatic hydrocarbons, pesticides, heavy metals. PAHs are also found in things such as coal that's burned, gasoline, and asphalt. So just to kind of give you an idea of what some of the chemicals are there in this. And that'll be the end of my soapbox for a 1970s smoking commercial. So stiripentol. This was approved by the FDA in August 2018 for, once again, Dravet, giving an idea of something else that it could be used for. It had been used for in Europe for many years prior to that, for almost more than 20 years. And then they slowly kind of introduced it throughout Europe, and then eventually it was approved in Canada, followed by Japan, then America. That is a very common trend with a lot of these medications, where the United States might allow for it to be prescribed, but it's been prescribed in other countries for years and years and years. Used for Dravet syndrome, usually with clobazam and valproic acid. Interestingly enough, clobazam with Dravet would make sense because it's a non-sodium channel-based medication. Valproic acid could worsen Dravet seizures because it does have some sodium channel effects, but it also has other ways that it works as well. So this one works on GABA. So it's kind of in the same realm as some of our benzodiazepines and barbiturates in how it works. It has a short to mid half-life, 4.5 to 13 hours. It's usually dose dependent. So depending on that will depend on how long it takes for it to build up in your system. It can cause decreased appetite and weight loss, and also tiredness. It's available as a powder as well as capsules. And dosing is 50 milligrams per kilogram per day, divided into 2 or 3 doses. We use this only in children. To be frank, I don't personally prescribe this to anyone. And once again, it's pretty much only given to Dravet patients. Fenfluramine. So this is one of the newer medications prescribed or approved by the FDA since June of 2020. Available for ages 2 and older. The old name was Pondamin. As well, I believe in Europe they might still call it that. Fintepla, as it is in the United States market. Interestingly enough, this was one of the phens in fen, which used to be an appetite suppressant back in the 70s, that was taken off of the market actually because of one of its significant side effects. It was causing a lot of heart issues, cardiac issues. And that's because they work in both of those medications, fenfluramine and phentermine, the other fen and fen, could cause cardiac issues. Phentermine acted as a stimulant, so it could cause cardiac arrhythmias, so like atrial fibrillation or other cardiac arrhythmias, whereas fenfluramine actually changed the heart itself, or people were at risk for it. It caused the valves in the heart to become abnormal, and thereby causing increased pressure throughout the lungs. So pulmonary hypertension and cardiac valvulopathy, as we say. It was discontinued pretty much internationally, except for in Brussels. And there they would continue to use it every now and then for certain syndromes. And it was found to actually help with seizure syndromes. Once again, Dravet syndrome. And we'll talk about the mechanism of action on this one and how it's unique. And then also more recently, it has also gotten FDA approval for Lennox-Gastaut syndrome. So this is now a little bit more ubiquitous, something we can use in a lot of our, more in our patient population. Obviously, it does come with some risk, which we'll talk about. So this is pretty unique. This actually works on serotonin, kind of what we mentioned a little bit with whether or not that's how cannabidiol or CBD works. But that's the mechanism here. So it acts as a completely different way. Half-life mid to a little bit longer. So now it could take up to 5 days for it to really get into your system. The side effects, the valve disease and the cardiac issues with the pulmonary arterial hypertension I brought up are pretty much a main one that we're looking at. Not because of the prevalence or how often it happens, but more of the just concern, because you don't want you to have yourself to have any heart issues. It's a restricted REMS program that providers need to be a part of before they can start prescribing this. So it's not just something any person can necessarily prescribe unless they go through this REMS program. Much like it was used back in the 70s, it can cause weight loss. So it causes anorexia. It can cause you not to want to eat. And then it goes through serotonin. So if you're on an antidepressant, it can also affect that serotonin expression as well. You could be put at risk for something called serotonin syndrome, which could be quite significant. It can raise your blood pressure as well. So hypertension is risk. And then if cardiac side effects develop, you have to talk about the risk and benefit of it. So the monitoring. Prior to them starting treatment, the patients need to get an echocardiogram because we have to see what their baseline function is. And then these individuals then have to get an echocardiogram every 6 months while on treatment. As you could imagine, that becomes a big social stressor, especially for individuals who might not be able to drive or might live in areas where they can't readily get to a cardiologist. The suppliers of fenfluramine actually do work with individual companies, though, as well, that can help find individuals who can get echocardiograms, and trying to work in conjunction with the epileptologist. The goal is to maybe even get the echocardiogram done during a follow-up. So there are ways to kind of maneuver that, but these are some of the responsibilities that need to happen if someone's on fenfluramine. And then even after they stop the medication, they need to get an echocardiogram 3 to 6 months following the stopping of this medication. Once again, this is seen less frequently, but it's something that we want to make sure we watch out for. It is an oral solution. It's cherry flavored. It's dosed dependent on whether or not they're also taking steripental or clobazam. And then once again, going through the liver, if they're on rifampin, we have to change the dosage. If they have any kind of liver or kidney issue, they should not be on the medication. The basic dosage is weight-based. And as you can see, if they're on clobazam, Onfi, or steripental, Diacom, they might have to change how much they're currently taking. But usually you're looking at a max dose of either 26 milligrams if they're on neither of those medications, or 17 if they're on either of those. Cenobamate, this was approved later in 2020 in November. This is currently approved for more of our adult population, so ages 18 and older. Sometimes we might try and get it for our little bit younger, like mid-adolescent group. This is also known as Xcopri. This is also used for focal seizures and has been shown to have great benefit as well. Has a much longer half-life, so 30 to 75 hours. It's a little bit more broad spectrum, and initially there was no clinically significant interactions. I have to change that because there are some clinical interactions we have to talk about. Works through a few different ways. It can block sodium channels. It can also work on chloride channels, I believe, and then GABA, but not through the benzodiazepine effect. people have had good results with this and how well it can decrease their seizure frequency, but there are some risks of side effects. Formulation, it's usually tablets. And as you can see, there's low dose as 12.5 up to 200. The goal is to get up towards 200 or even above to a max of 400, but you have to go slowly. So this, kind of like lamotrigine, needs a titration. And as you could probably guess, we'll talk in a second why you need a titration. But as you can see, it's pretty slow. It is a once-a-day medication, so that is one of the benefits of it. If you have liver disease, if it's mild to moderate, they have to be at a lower dose. If it is severe, they can't be on it. Same thing with kidney disease. This also is a Schedule 5 medication, so this also needs prior authorization before it can be given to the patient. And typical side effects, as you can imagine: dizziness, lightheadedness, fatigue, double vision, issues with gait, the hypersensitivity reaction. There is a risk of skin rash. Some may concern if it's Stevens-Johnson syndrome, but also this other skin disorder called DRESS, otherwise known as drug reaction with eosinophilia and systemic symptoms. That becomes the big issue. And that's why we have to start off at such a low dose and go up. It can interact with other anti-seizure medications, so you have to change the other seizure medications if they're on these two at the same time, because it can cause more sedation, more dizziness, or toxicity. So clobazam is very common. I've seen that a few times where people might get tired, a little bit more side effects from that, as well as lacosamide, phenytoin, phenobarbital. So you just have a certain way that you might have to, as they're going up on the titration, go down on some of these other meds. Now, the next picture is graphic, but just to show you what DRESS looks like, because people will say, oh, I think I have a rash. DRESS is very significant. So if people have DRESS, it is usually kind of like Stevens-Johnson. It could involve the mucosa, so your mouth, your nose, your inside of your ears, even your eyes, surrounding your eyes. But it is quite significant. A lot of people talk about the rash, but it's usually like eczema or dry skin. But nevertheless, we try and make sure that we evaluate them to see what it looks like. It's pretty rare. Initially, when the study was first coming out, it was 1 person out of 600. And then that was associated, though, with saying, okay, let's start them on 200 and see how it goes. And then they saw that a few people got this. So after starting at a lower titration and starting dose, there were no cases seen as the studies went on and on. So that was one of the benefits, at least, of starting the lower dose. It just means that it might take some time for them to go up on it. And it's not always readily available in hospitals, as are some of these medications. Ganaxolone is the one of the newest. It's also called Stalmi. This is, as of right now, very specifically available only for a specific type of epilepsy called CDKL5. This is a almost entirely female predominant epilepsy syndrome. It's for ages 2 and older. There are some ongoing studies for other genetic-based epilepsies, but it's pretty rare. And there are other studies that are going on for ganaxolone. This also goes through GABA, so kind of like our benzodiazepines and barbiturates. Usually they have to take it after a high-fat meal. Half-life is about 7 to 10 hours. Side effects, the seasonal allergy and upper respiratory infections are the things that makes this a little bit more unique and what people might describe kind of a stuffy sensation. But it is a risk with it, as well as sedation, as are most of the GABAergic medications. It is an oral solution, cherry flavored, sugar-free as well. So it's compatible with ketogenic diet, which we'll talk about in a second. And it is weight-based, Schedule 5 medication as well. And this one, I think they're trying to work a little bit more with for the future. We'll talk a little bit about ongoing research and then talk briefly about some of the other things, which will be more of a review. But charismate, kind of similar to what we were talking about with Xcopri. As you can tell, they're in the same kind of family as the Baumate families. They tried to approve this back in August of 2009, but it had insufficient efficacy. They're trying once again to bring this back. As you can imagine, a lot of these meds take a long time to go through the full process of FDA approval and what have you. So, but down the line, they might see charismate start to poke its head back through as well. Everolimus, so this is potentially anti-epileptogenic. It's actually used for other uses as well, things that are going through mTOR, which is this genetic pathway which can be associated with other syndromes. The use for it here is using another mTOR-based disorder, such as tuberous sclerosis. So it is used as an adjunctive therapy with people who have seizures in the setting of tuberous sclerosis. Now, I say anti-epileptogenic because there are a lot of other things that can be involved in mTOR. So usually it's used with individuals who have what are known as SEGA tumors or subappendable giant astrocytomas, which is pictured here. But other mTOR overactivation pathways include things such as gangliogliomas, so certain types of brain tumors, hemimegaencephaly, which can be associated with certain genetic disorders. Here, the right side, which is ironically enough the left side of the screen, the right side is bigger than the left side of the brain. And then focal cortical dysplasias, which are marked by these arrows, which is a migrational disorder. So when your brain is first forming, this is part of the tissue that's not actually going to where it needs to be. So mTOR might be involved in that. So the question is whether or not these medications, like everolimus, might be able to more specifically attack where the seizure might be coming from. These are often, very often, sites for surgical candidacy, which we'll very briefly touch on in the end about. But those could be another consideration. There are a ton of side effects about with this medication. So it can cause stomatitis, so irritability around the mouth, infections. It's kind of shutting down the immune system to a point. Can affect your red blood cells. It can affect your liver function tests, as well as cause hypertriglyceridemia and have some other nasty side effects down the line. But this is at least food for thought for the future. Lorcaserin is FDA approved for weight loss. It's also known as Belviq. So it's actually very similar to Fintepla or fenfluramine. It also works on serotonin. Specifically, it's working on serotonin receptors that are limited to just the brain, not on the heart. So the theory is that it's going to be used to work kind of like fenfluramine, but not cause the cardiac valvulopathy and the pulmonary arterial hypertension. So maybe it could help with Dravet syndrome as well, kind of like how the goal with fenfluramine is. And it has been shown to reduce seizures in some of the studies that have been produced in people with not only Dravet's, but also Lennox-Gastaut, as well as other epilepsy syndromes. So something to keep in mind for the future. And that one has been used in certain studies throughout the Northeast as well as the country. Half-life, 11 to 19 hours. Side effects, as you can imagine, decreased appetite and weight loss just without the cardiac valve issue. And people who were in the study, they did take anyone who was on sertraline out because they didn't want to have serotonin syndrome. It is a scheduled medication, so they need prior authorization. I'll very quickly go through anakinra. It's actually trying to block a immune system irritating chemical, if you will. So human interleukin-1, which sometimes can be associated with tumors, but also be associated with inflammation. So inflammatory processes is what it's typically used for. The thought is, can it do that with epilepsy syndromes associated with inflammation? There are certain inflammatory syndromes that are seen here: Rasmussen's, focal cortical dysplasias, tuberous sclerosis, gangliogliomas, DNETs, as well as even febrile seizures. People who have intractable febrile epilepsy, which can sometimes happen, could this be a possible use? We don't know. The theory is you're just trying to decrease the overall inflammation in the brain, which kind of is in the same mentality of when we were talking about ganaxolone. Ganaxolone is actually in the family of kind of a neurosteroid. So it's kind of like using steroids to help kind of slow down or even stop seizures. Half-life, it's actually pretty short. Usually they'll get it and then they will get infusions and have to come back. They can get injection site reactions, and very rarely it can shut down parts of the immune system. So once again, food for thought for more of our inflammatory epilepsies. There is an entity known as FIRES, which is kind of like a refractory epilepsy syndrome that's induced by a febrile illness. So there have been even some people that maybe have seen this can help, but that's still very early on in planning. And then I'll kind of end with talking about some of these. new formulations. There had been thoughts of how can we get these into people if they can't swallow, or if they're in an emergent setting and they can't swallow. These are just a list of some that have been used. They've tried many times to have an intravenous carbamazepine or oxcarbazepine or eslicarbazepine, because people were and still are very often on those medications. They tried, and I don't think that they've been able to bring it back, but it was taken off the market, unfortunately. A lot of what we'll talk about is either buccal or nasal sprays. So buccal clobazam is kind of unique because this was approved in 2018. It is a version that can be inserted into the cheek, and it's available in 5, 10, or 20 milligram sheets that can be placed in there. It's beneficial if someone has increased salivation, difficulty swallowing, or any other medication form they're not able to take. So I do have some individuals that I've tried to get this medication, also known as Sympazam, to help kind of facilitate them getting their Onfi or clobazam. So it's a longer acting benzodiazepine, Onfi or clobazam, which this is a different way to introduce it for them. Onfi is GABAergic, kind of as we said before, it's in the benzodiazepine family. The nice thing is that it does last in your system longer. So rather than having to take a lot of benzodiazepines more frequently, you could just take one per day or twice a day. Side effects, clobazam can cause constipation, sedation, drooling, ironically enough, and then difficulties with fever, pyrexia. And this is just showing some of the formulations and our weight dosing. As we talked about before, it can interact with CBD. Just like any other opiate or benzodiazepine, very specifically, it can cause respiratory depression, so we do watch out for that. And alcohol can also increase the levels by 50%. And this is also a Schedule IV medication. Intranasal diazepam, otherwise known as Valtoco, introduced by the FDA in January 2020. It's an abortive anticonvulsant for seizure clusters. It's for ages 6 and up. This is just showing what it looks like. We'll look at both this as well as intranasal midazolam or nasalam in a second. This is what they typically look like, though, with a kind of plunger setup that goes into the nose. The real goal of these medications is to replace rectal diastat, which I always tell patients sounds about as fun as it could be. So this is trying to introduce something that's a little bit more humane, as well as better tolerated for everyone involved. Valtoco or intranasal diazepam is weight-based. It can vary by age. They might require either 1 or 2 nasal spray devices, and these are available in an individual blister pack. So as you can see, 5 and 10 milligram doses, which once again are based upon these weights, you get 1 device and you put it in 1 nostril when they have it. Whereas the 15 and 20 milligram doses, you get 2. So you do 1 in each nostril. So when they open the pack, they get 2 and they do 1 in each. It's also a Schedule IV medication. This one has a longer half-life, which we'll talk about in a second. So that's one thing to consider, at least. Nasalam, or intranasal midazolam, was approved by the FDA in May of 2019. So this is an abortive anticonvulsive as well. This is approved for ages 12 and up. It's available in 1 dosage, 5 milligrams. So it doesn't have to be used based on weight. The other thing that is different about this medication is that if there's a seizure cluster lasting longer than 10 minutes after the first dose, a second dose can be given. And a lot of that has to do with the half-life and the bioavailability, what have you. Once the 2 doses are given, you shouldn't give another one. No hepatic or renal dosing noted. It is also a Schedule IV medication like intranasal diazepam. So both of these work on GABA, and the half-life is really the main difference between these, let alone other things, but this is the main thing. Intranasal midazolam or nasalam is pretty quick, 2 to 7 hours for the half-life, whereas intranasal diazepam or Valtoco is 49 hours. So there's different uses for both of these. And it's gone back and forth. Which would you rather have? Something that you take 1 of and now it's in your system for a long period of time, or something that you can use 2 of to kind of help break up a cluster? And they've done studies on this where they'll look at whether or not it's better for maybe, for example, things where you want to retain your consciousness more quickly afterwards. Maybe you'd want to use something like an intranasal midazolam, because that way you can take it, and then if they're still seizing 10 minutes later, you take another, and maybe you just stop it at the start. Whereas other ones where if someone's been known to have big convulsions, which are very risky for other issues, or long convulsions, maybe you want something that's in the system longer. So that way it's trying to help kind of slow it down or stop it. And the other theory is, would you want to do intranasal midazolam for that to kind of help stop at the get-go? It's hard to say. Realistically, for both of these, if the seizure is still going on after 5 or 10 minutes, especially if it's early on in the diagnosis, a lot of the times we will tell people to still call 911, be evaluated early on in the course. If someone's known to have, seizures that are very frequent or clustered, they don't necessarily have to do that. But just to show you the two differences between the medications. Benzos do carry a slight risk of glaucoma. It can cause mood changes because there's a benzodiazepine. Most often, people would talk about maybe like a bloody nose or nasal discomfort with a lot of these. They should avoid taking with cytochrome P450 inhibitors, which is going through the liver. This is what it looks like. Plunger goes right up the nose, and finger grips, and they push down. That's what both look like. And just to kind of show how the introduction would, the plunger remains inside the spray until the dose is given, and then they throw away the spray after the use. With Valtoco, they would do one in one nose and one in the other. And then there's also extended release formulations of a lot of these medications that have been coming out. That's to try and decrease side effects and also improve compliance, because people who have 2 or 3 times a day they have to take a med might not be compliant with it. So I unfortunately don't have much time. I'll just very quickly kind of touch on some things. The ketogenic diet, usually it's used in the population for peds. Sometimes it's also been shown for people who are in status for very prolonged periods of time. We don't know how it works directly. Is it the actual ketones itself that are causing the seizures to not happen as much? Is it changing the pH of the brain? The more acidotic your brain is, the more inhibited it is. So maybe it's trying to shut it down. There's also been theories, do specific types of fatty acids work better than others, like stearic acid versus, oleic acid and what have you, omega-3, 6, 9, all these different things. Do they work on the channels that a lot of these other seizure meds work on? Hard to say. I won't go through all this, but these are all the different things you have to do if someone's truly on a ketogenic diet. And I say this because so many people will say, oh, I'm on the ketogenic diet, and they're walking, talking, and this is not someone with epilepsy, just someone that you're talking to. For someone really to be on a ketogenic diet, they have to be getting a lot of different things checked up on frequently enough to make sure that there's not the complications that come with eating nothing but a high-fat diet. And it puts you at risk for things such as heart attack, stroke, hypertriglyceridemia, etc. People need to review their med list with a pharmacist. If they're in the intensive care unit, that specifically needs to be evaluated, because a lot of these other meds I talked about might have sugar in them, whether or not it's the pill or even, like I said, the suspension, especially. That's why it's nice that a lot of these newer suspensions are having no sugar in them. Other meds might have high fat content as well, which could worsen things. Steroids can affect fat metabolism as well. And even sometimes soaps, shampoos might even have a little bit of carbohydrates on them. ECT, I almost never see anyone getting this for seizures, but you can. It's primarily used for affective and schizophrenic disorders, typically severe depression. Electrodes placed over the frontal temporal regions, and it actually is causing a seizure. So don't know why, but it might actually increase the seizure threshold. It might block the brain from teaching other parts of the brain to start seizing, because you're literally fighting fire with fire. And then also transcranial magnet stimulation, which once again, I almost never see. It's usually used for the psychiatric realm. The theory is that you're using an electromagnetic magnetic induction, which is trying to cause inhibition in the brain, because electrical activity actually has a magnetic field around it, which that can get into a whole other physics and what have you. But gene therapy also being used. The theory is that you're actually trying to change the epileptic network as well. That was a very common topic at the American Epilepsy Society this year. And it's been shown potentially, but that's way down the line, I think, of what they're going to be using. Problem is where do you implant it? When do you implant it? Do you implant it via the vein for your whole body, or do you implant it directly in the brain where they're seizing from? So unfortunately, I'm pretty much out of time. The one thing I was going to say is I usually end with this, but I don't know if I can have the slides available for other individuals. All this is just saying is talking about other things outside of medications, such as VNS, RNS, DBS, talking about some of the surgery and all the people involved with it, some of the ways that we go about surgeries, because obviously this is a whole other conversation in itself, surgical techniques, and then that's pretty much it. So I apologize for going over, but any questions, please let me know.
Anybody has any questions, you can put them in the chat or come off mute at this point. I know Dr. Lansing has a pretty quick turnaround for his next patient in a different area than he is right now. So thank you so much for this. This was so helpful and so informative. But again, if anybody has any questions, speak now or forever hold your peace. Just kidding. You can email me and I can make sure Dr. Lansing gets those questions to answer.
I have a question.
Yeah.
I know you had mentioned you try up to 3 medications to see if it works for the individual. Even though the effective rate is lowered, going down to 1%, do you ever go beyond the 3 trials just in case that patient is part of that 1% effective rate?
Yeah, absolutely. And there's a lot of reasons for that. One is to talk about, okay, now I start prepping people after, and this is myself, I start prepping people after the first medication has really kind of gone, because now you're in the other 50%, so to say, if you truly have failed it. And I start to say, okay, here are your medications. Now, just so you know, there's a chance you might not be able to respond to anything else. Here are the options. And then the options we start talking about, which I didn't talk as much about with this, but devices or brain surgery, where the real chance that seizure freedom is going to occur with really resection of the part of the brain that's seizing. That's the best. But there's a lot of factors in that. There's also people who go through the surgery who don't have that seizure freedom, which, as you can imagine, is also very frustrating because now you've gone through brain surgery and don't have that. Devices are a little bit easier to kind of talk about, but then they also have their own risks. Because a lot of times the devices might be that they try to get something implanted, or try to get something resected, but they can't, so they need a device. So they already went through the surgery. Or there is VNS, which is a non-brain surgery-based device where it's implanted under the skin. So a lot of people might be very keen to that. And there's a lot of other benefits of VNS, might decrease the risk of things like SUDEP and what have you, based on some premature study or early studies that they've shown. But I bring all this back to, after I talk about all that, people are like, I'll just try another med, because they don't want to have to go into a lot of that other workup. So then I will be like, okay, you're on 3, let's try 4. It becomes really tricky too, because now I'm like, well, I don't want you on 4 if you're going to be a zombie on it, or you're going to have other issues. So why don't I want you on 3, but I need to get you up on 4 before I take 3 down. And then sometimes what'll happen is I get them up on 4 and then they go into the hospital and have a cluster of seizures for who knows what reason. And then they come back to me on 7 because like the ICU just hit them with all different kinds of things. So it becomes a little bit of a slippery slope, but I try, the goal is, and they asked this at the American Epilepsy Society this year. They were like, it wasn't, I would say a show of hands, but it was actually like an app that everyone had to put in, where they said, who thinks this is the right amount of medications any patient should be on? 1, that's medically refractory. 1, 2, 3, or more than 4. And almost everyone said 2. A few, the next closest was 3, but almost no one said 4. And some very optimistic people said 1, but it's we want to have you on the least amount of medications as possible with the least amount of side effects, but sometimes it's just not doable. And the theory is it's rational polypharmacy. if we do have to have you on a lot, we want to make sure there's multiple mechanisms of action working rather than just like, you're on 4 sodium channel blockers. You're going to be extremely dizzy. So yeah, that's kind of the long and short of it.
Thank you.
Dr. Lansing, there was one in the chat. What do you think about stress prevention and seizures?
I think that's very, very, very important. It's paramount. Like the one thing I didn't talk about this is, you have to control your own body and make sure you're getting enough sleep, making sure you're eating and drinking well, things that you wouldn't think you have to tell people, but you do at the end of the day, because everyone needs that reminder. That's stress is definitely one of them that can cause it. Stress can, sometimes people will make sure that they augment their diet a little bit. There's been some studies talking about whether or not certain vitamins and certain supplements might help out with seizures. I would not ever recommend just using that instead of seizure medications. But like sometimes people will take certain B vitamins. People will talk about pyridoxine, but that's also usually specific for specific type of epilepsies that are pyridoxine responsive. So, but yeah, stress can definitely sometimes worsen.
Beautiful. And the next was, my son is 9 years old with LGS. He has been on phenobarbital since he was a year old. Is it possible to ever reduce his dose or get him off of that safely? Every time we try to reduce it, he has breakthrough seizures.
It's difficult. Phenobarbital, while it's a great medication, it is in your system quite a long time, and it is probably the poster child for withdrawal seizures. It's notorious for withdrawal seizures. When people go on it, to come off of it, it takes a long time to go down on it, let alone ever get off of it. I have people who haven't had seizures in 50, 60 years, and they're still on it. And I ask them, why are they on it? And they're like, oh, well, I never thought to take it off. And so I'm like, if you want it, they're like, I want to go off it now. And I'm like, okay. So it could take a year, like months to a year, if not longer. And then it also becomes hard because then you play a little bit of a game where one medication might affect the metabolism of another. So if they're on another med that goes through the liver, for example, then it can become much more complex with how much they're interacting and how much it might affect whether or not they can come off of it. The body changes, especially in a 9-year-old. Going through puberty and what have you, and as he gets older, it's definitely possible. Sometimes they might just have to change how fast it goes, as long as, a tincture of time might be the ultimate prescription of that, just making sure that you slowly come off of it. It is possible, but I will add this, there are some people that is their thing. Like they're just very, very responsive to a med and it stopped their seizures, or they're very, very responsive to it. And if they change it at all, it could cause them to seize. So it's hard to say, but it is possible.
Next is, how successful is trying to control triggers?
It depends. And they were saying, how successful is it to try? It really depends. So the hardest one is people who are photosensitive. And I know there's been a lot of patients who will come in and talk to me about like certain types of lights and certain situations. People will talk about blue light glasses and other external ways they can stop it. If you can, to the best of your ability, really avoid your triggers, it could decrease your seizures, of course. There are epilepsies that are reflex epilepsies where you do something and it causes a seizure. Pretty dramatic ones too, like eating epilepsy. Every time someone eats, they have a seizure. So obviously you can't live your life not eating. They've tried ways of doing that, of taking a seizure med right before you eat. There's hot water epilepsy where people have, in parts of like Sri Lanka, where they would have hot water dumped on them and then they would have a convulsion. So avoiding the trigger is definitely the best you can do. Sometimes they might also time your seizure med with the known time you're going to have a trigger, if you have the luxury of doing that. Some things you don't. Like you don't have control over, flashing lights at 20 hertz that are coming at you from whatever way. And it's also hard with things like sunflower syndrome and a lot of other rare syndromes that people might have, but you try your best.
All right, thank you. Does anybody else have any final questions for Dr. Lansing? All right, any final questions can be emailed to me. My email should have been in your registration, and I will make sure they get to Dr. Lansing. But if there's no further questions, I believe we can conclude this. Again, thank you so much, Dr. Lansing. That was very informative. I hope everybody got a lot out of it. I will make sure to send out the slides as well as a recording of the presentation for anybody who might want to get a refresher on some of it, because there was a bit of information covered today. But again, thank you, and we can conclude.
Thank you, everyone.
Thank you.